Professor Paul Keel.
So the Imagex Institute is part of the University of Sydney, and it is a place of amazingly talented people, mostly physicists and engineers, who work to invent new technology to image and target cancer and other diseases.
Okay, that's the broad strokes. Is it specifically what was the requirement for it to come into existence at all?
So the Imagex Institute really came into existence as part of the ACRF grant that we were awarded and received in 2017. And that enabled us to build some world-unique equipment for which we could then do research to improve the lives of cancer patients, from technology to both image their cancer and also to treat the cancer with radiation. And the problem we're trying to solve is that there are 20 million new cancer patients diagnosed every year, and 10 million of those need radiation therapy. And radiation therapy is a way to uses radiation beams from outside the body to target cancer inside the body, which of course we can't see from outside. So we need to use imaging probes, we need to use physics to tell us where in real time is this cancer, because human beings are dynamic. We breathe, our hearts beat, we digest, and every time there's motion of the body, that means that the cancer is moving as well. So we need to know where it is precisely. So we're hitting the cancer with the radiation beam and not surrounding critical structures such as lungs, such as the heart, such as the bladder, such as the rectum, and things which can really cause significant toxicities and quality of life for cancer patients. X-rays were discovered in 1895 by Wilhelm Conrad Röntgen, and interestingly, by 1986 they were used for treating cancer, and just sort of that gap and that ability to translate sort of discoveries, this amazing discovery of the X-rays into a medical tool has just been phenomenal. And the X-rays are really the basis for a lot of what we're doing today. And as a scientist and also as an inventor, it's amazing to look back on how people can really see, visualize, and create technology that hasn't existed. Like we look back and we see, okay, that's how things can be done, but it's so much harder to have the foresight and vision to be able to create the future. And that's something that we as inventors and people who are trying to improve how cancer patients are imaged, diagnosed, and treated, that the innovation is a really core part of what we do. So we're still improving technology that has been around for some time and repurposing it to account for the dynamic human body and being able to spare patients from the side effects of cancer using these tools that physicists have invented from over 125 years ago. The X-rays that Röntgen discovered are lower energy, and they're good for imaging. We've all seen the picture of his wife's hand with the ring, but they don't penetrate that far into the human body. And so it was really the developments of radiofrequency technology, and a lot of that happened during the war, with World War II, which was then applied to accelerate electrons to nearly the speed of light, which enabled us to have the higher energy X-rays that we use today. And so these X-rays that are almost 99.9% the speed of light hit a high atomic number target and then create X-rays which can be used to penetrate deep into the body and will treat tumors much more effectively within the body, rather than just surface X-rays of the 1895 era.
Can you help me unpack that a little bit further? It's simpler, because I got up and it's just like, well, what happened in wartime? Why did that accelerate the X-rays? And there was probably a major breakthrough, which I think you've said, but I'd like to unpack what that was from the original X-ray.
So one of the developments during World War II was the advancing of radar technology and using radio frequency waves, and that the stimulation of that technology, being able to get more and more powerful radio frequency waves, led to the ability to use those radio frequency waves to accelerate charged particles. And this created a linear accelerator, which is really the core of what we use to treat cancer patients today. And so X-rays are accelerated to 99.9% of the speed of light in these structures, and then they hit a high atomic number target. And from the target, when they hit the target, the X-rays are slowed down and create X-rays. The electrons are slowed down and create X-rays, which we then use to treat cancer patients. So there's so much physics that goes into the tools that we're using to treat cancer patients today, and it's we're really building on the innovations and the learnings of over a century of technology development to achieve the really amazing technology that we have today. And what we're doing is also saying, well, how can we make this technology even better as we look into the future and the next 100 years of treating cancer patients? So the radio frequency waves are injected into small cavities, about 10 centimeter to 10 centimeter cavities, and within that, electrons are injected at one side, and the radio frequency energy, the very high intensity radio frequency energy, when it's timed with the injection of the electrons will essentially accelerate within as part of the radio frequency wave and to the exit of the next cavity, and that will continue for 3 or 4 times until, with the electrons getting more and more energetic within each cavity, at which case it will strike a target. Which case they will strike a target, and the electrons are then converted into the therapeutic X-rays.
Okay. Can we simplify that explanation? No, it's okay if you can't. Just like, excuse me, I get to clear my throat.
So the X-rays, electrons are injected into this radio frequency cavity where there's radio frequency waves resonating within that cavity. So you've got this very energetic cavity, and so that some of the radio frequency waves energy passes to the electrons and accelerates the electrons across the cavity. And if they in only sort of three or four times, if we do that 3 or 4 times, the electrons go from very slow speed to almost the speed of light. And so we're dealing with relativistic particles. And the relativistic electrons then hit a high atomic number target and create X-rays, which we use to treat cancer patients. How we create X-rays to treat cancer patients today is just an amazing combination of physics and technology development that has gone on for decades and even more than a century. And how we treat cancer patients today, we use these high energy X-rays, and these are created from electrons being accelerated in small cavities, and essentially like surfing on a wave. And they go through a cavity, they get more energetic and then more energetic, and after a few steps, then they're almost the speed of light. They hit the target and they create X-rays, and these X-rays then go into the patient and target the cancer. So the X-rays can kill cancer in 2 ways, either by directly damaging the DNA within the cancer cell, causing it so that it can't reproduce or losing the ability to reproduce, or it can create ionizing particles such as hydrogen hydroxyl radicals, which then interact with the DNA. X-rays damage cancer cells by interacting with the DNA, and if they cause DNA damage and they don't have the ability to repair, then that cell will die. And so we need to have a lot of X-rays to be able to have enough energy and enough damage to enable to cure an entire cancer. The challenge that we have is that X-rays also damage normal cells, and the balance of using the X-rays to treat the cancer and spare normal cells is something that is personalized for every cancer patient, for every treatment that they have. And this fine balance between hitting the target and curing the cancer and reducing toxicity by missing vital tissues is something that, again, we're using the basis of physics and targeting technology to be as fine as we can, essentially using these X-rays like laser beams, like scalpels, to really shape the radiation dose just to the target within the patient's body and spare what we can. We can utilize the biological differences of cancer cells when we're treating with radiation, because even though cancer cells can be very similar to other cells in the body, and they've come from other cells within our body, but their ability to repair themselves is slightly less than the surrounding tissue and our healthy cells. So we can use that differential of the cells to be able to make radiotherapy a little bit more effective. And so for the same amount of damage, for the same amount of radiation energy, we're damaging the cancer cells more than the healthy cells.
I think that's good, but I think you can simplify it even more. If cancer cells are more susceptible to X-rays, that's what you're counting on, is it? Or just
yes, yeah. So one feature of cancer cells compared to the rest of the cells in our body that we're trying to spare is that their ability to repair is a little bit less than the normal cells and to repair the radiation damage. So we do rely on that increased susceptibility of the cancer cells when we're treating cancer patients, and often we will treat over multiple days to really take advantage of that repair. Radiation can be made by humans. We can make it from the X-rays that we use to treat patients, which are essentially via machines we can turn on and off. And radiation, it comes from the sun and the solar radiation as well. And we can also make it in nuclear reactors and particle accelerators. And there's also radioactivity that occurs naturally in the elements. We'll have potassium in ourselves today, and so we are radioactive. Every day we get radioactivity from the sun. When we take a plane flight, we get more radiation. So it is really part of daily life is this exposure to radiation. And so our bodies do have the ability to essentially cleanse. That this radiation does cause damage, and our bodies do have the ability to cleanse the radiation and the radiation damage that we're receiving all the time. Radiation is a known carcinogen, and it's sort of ironic that something that we know causes cancer that we're using to treat cancer. And the reason is that because it's effective for treating many cancers. And would we like to have something better than radiation? Yes, but it's the best we've got. And the challenge with all of the cancer treatments we have is that they all have side effects. And part of what research does is just to try and improve that we call it the therapeutic ratio, and how we can purpose, whether it's minimally invasive surgery, better chemotherapy, immunotherapy targeting, or radiation, to increase that difference between the therapeutic ratio of giving enough radiation to improve the chance of curing the cancer and minimizing the chance of causing harm to the patient. The therapeutic ratio, it's the ratio between achieving the treatment goal, such as curing the cancer, and reducing side effects. So if we can really spread out with the same amount of radiation by improved targeting, for example, being able to get more to the target and less to normal tissues, we will improve the therapeutic ratio. More patients will be free of their cancer without side effects. So ultimately, what we would like to achieve is that we're putting radiation just in the cancer and not anywhere else. And that would be the holy grail. And it's not achievable because of the laws of physics, but we want to get as close as we can to that. So probably one of the biggest achievements that we've had is inventing a method that can image patients as we're breathing, and so we can see the motion of the tumor throughout the breathing cycle. And this is a technology that's now used everywhere around the world and has been used to image millions of and treat millions of lung cancer patients every year, which is something that has been incredibly rewarding. So we've got that track record of being able to make significant change to patients' lives. One of the focus areas that we're currently doing is real-time targeting during treatment, being able to know where the cancer is sub-second at all the time while the radiation beam is treating that patient. And we've developed technology using X-rays that we've been able to use for patient treatments for prostate cancer and liver cancer, and we've in 2 successful funded trials. And that technology is now being commercialized by an Australian startup and will be able to treat millions of cancer patients in the world. So one of the most satisfying parts of what we do is to be able to see the technology make a difference in the real world. So it's very, very focused, very translational, being able to start from that, the idea of that discovery, that invention through computer simulations, clinical trials, and then into a product that doctors could use to improve the lives of cancer patients.
When did radiation therapy start? You're saying just after the war, didn't it?
So radiation therapy started essentially in 1896, the year after the discovery of X-rays, and just seeing that with skin cancers that they are visible, and the thought that, well, if we can use these rays to reduce damage to cancer patients. And so it was a very quick transition from discovery to treatment. And of course that then evolved, and through a series of pioneering works, looking at different parts, being able to treat in different parts of the body, and to evolving to really where it is now, which is a very high tech, streamlined operation that's non-invasive for patients. So there's probably been several innovations in radiation therapy that really form what we're doing today. One is going from low energy X-rays that Röntgen discovered to the higher energy X-rays that we can use to then treat more deeper seated cancers within the body. We can the integration of imaging as well into the radiation therapy process, and being able to understand where inside the body the cancer is, has probably been another really remarkable innovation and evolution that is still very much evolving today. We're also seeing more functional imaging being integrated into the treatment. If we're sort of looking forward into the future, really understanding a bit more about the biology and physiology of the cancer and surrounding normal tissues, and using that to inform where we target, making sure that we're targeting the most radiation on the most aggressive and resistant parts of the cancer, and also sparing the most healthy tissue surrounding it. So I think both the film industry and radiation therapy have been really transformed by the digital revolution. And we used to take physical films of patients. We would take a film, we'd walk into the dark room, process it while the patient is still lying, waiting to be treated, bring it back, and then use that to make a treatment decision. All the while we're asking the patient to stay still, which they're doing their best, but we're dynamic human beings, and they are breathing, twitching, and the anatomy is changing. Now we can take those images digitally in sub-second, and the ability to then make such more active decisions in real time or near real time of where we should be putting the cancer has, I think, been one of the big innovations that I've seen during my time as a medical physicist. So I think one of the biggest breakthroughs that I've seen and it's something that really has driven most of my career, has been the ability to understand and manage tumor motion due to breathing. So we've been able to develop technology that doesn't just treat the patient as static, but understanding that we're breathing and imaging while we're breathing, and so we can see how the tumor changes and moves within each breathing cycle, and also taking that technology, because we will breathe differently on the day of treatment, and being able to take that technology to the treatment and understanding on the day where the cancer is to be able to improve the targeting. That's been one of the biggest innovations that I've seen during my career. When you breathe, your cancer moves and it ruins your aim. So we need to develop tools that we can hit the moving target. So when I was in high school, I really enjoyed physics and understanding how the universe worked and thinking about the big picture, what's going to happen to the universe, stars. And then I got to university and was studying physics and mathematics. And I got to do a summer research project on medical physics. And I hadn't heard of medical physics before. My previous summer vacations were picking up hay in the fields. And so it was actually nice to be in an air-conditioned office and working on medical physics. And what my problem was, how do we understand the radiation transport within the human body? And from that summer research project, then I ended up understanding what medical physics was. I got to go to a conference on the Gold Coast, which I thought was pretty good as a young 20-year-old. And really combining what I really love, which is physics, with being able to help people, the innate ability or the innate want to improve human health that I think most of us have. Combining that together in the field of medical physics is something that I've been doing ever since then as an undergraduate, and that took me to Adelaide University, where I did a master's and PhD, and it's really driven my research career since then, and been very fortunate enough to be able to really to live the impact that the technology, the physics, applying physics to medicine has had on patient outcomes, and being there and seeing the human side and seeing some of the patients that we are treating with our technology is just the most satisfying part of work. So to me, the combination of using physics, which is what I love, what I studied at school, what I studied at university, and combining that with medicine, and we're all got an altruistic bent in us and really want to help humanity. And so if you can combine what you love with what helps people and make a career out of it, is just something that is fantastic, and it's been incredibly rewarding and satisfying for me. And to be able to take what we've been doing, the product of our research, the innovations, and use that to treat patients on clinical trials, and is something that's been incredibly satisfying. One of the patients that we treated, John Frazier, who was interviewed on television, and because he was involved in one of our clinical trials, instead of having his prostate cancer treated in 8 weeks, he got it treated in 1 week. And with the improved targeting, he described this, and this enabled him and his wife to go to Hawaii for their 50th wedding anniversary with their family. And I was at the interview, and I was just in tears at just like how much that meant to him, and that our technology really enabled this, such a meaningful change in his life.
That's a great story. Professor Paul Keel, take 3.
So I'm a medical physicist, and that means that I get to combine physics, which is what I love, what I studied at school and university, with medicine. And the ability to use what I love to help patients is just incredibly rewarding.
Sounds like you meant that.
Being able to to take the technology and see the patients on our clinical trials and what it means to them is just unbelievably satisfying. And as far as career achievement and sort of satisfaction that I've had in my career, it's just phenomenal that being able to sort of experience that in multiple times as part of my life, and knowing that I've made an impact is just so satisfying. Some of the top three experiences. Probably the first one, I was in Virginia and running a clinical trial on patients with lung cancer. These were predominantly African American patients, and 24 out of the 25 patients we approached to give their time to us agreed. And because they were just like, "Doc, anything you can do to stop this burden from other people, I will give my time for." And that just was so, just I guess resonated with me personally, just how important it is what we're doing and what cancer research is, because of the patients and what they go through, and how important it is just any cancer research to improve patients' lives, and their experience is so valuable. Another example is with John Frazier, who was a prostate cancer patient enrolled in one of our trials, and he was treated in five days instead of 8 weeks of radiation therapy because of our targeting technology. And he could explain in his words what this meant as far as hitting the prostate and minimizing damage to the rectum and bladder. And also it allowed him and his wife to go to Hawaii for their 50th wedding anniversary with their extended family, and not for him to be being treated at Westmead Hospital. And John did an interview and explained this, and I was there in tears, crying at just how much that touched him. Another example, Steve, who is a wheat farmer from Aberdeen, a couple of hours from Newcastle. He waited to go on one of our trials so he could be in Newcastle for 5 visits instead of 8 weeks. And for him, as a working farmer, it's almost, he couldn't really afford to be in Newcastle for 8 weeks, but he could afford to be there for 5 days. And got a text from the treating physician saying that that the patient had 5 years after treatment was well, no side effects, no sign of recurrence, and sends his thanks. And that is just something that is incredible to be part of. Yeah, so I'm a small town boy from a town called Te Awamutu in New Zealand, and went to high school. My parents were high school teachers, which is always tough when you're at the same school as your parents. We went to university, the University of Waikato, and studied physics and mathematics, and that's where I first got into medical physics. And I did a summer project there, and my advisor had just finished his PhD, and he went to Adelaide, and so I followed him and went to Adelaide and learnt more about medical physics as part of a master's program and a PhD. And then my first, real job was as a lecturer at the Queensland University of Technology. And I was just on a 1-year contract, and I was enjoying it. But because of the nature of short-term contracts, I then spent a year at Liverpool Hospital in Sydney, again on a 1-year contract. So near the end of that, I thought, well, geez, I should apply for a job, and applied to a place called Richmond, Virginia, in the United States, which had a very strong radiation oncology department. And fortunately, I got a job as an assistant professor there, and really that's where my research transitioned to what I'm doing now, which is accounting for the dynamic human body with cancer imaging and targeting, where I am today, to be able to research and improve how we can image and target cancer in the dynamic human body. And after time at Virginia, I then was appointed as the director of radiation physics at Stanford University, and spent 4 years there managing the the research, educational, and clinical activities of a busy department. And I think Stanford is just an amazing place. It's a beautiful campus, but there is always so much innovation. In the first month I was there, 2 Nobel Prizes were given, heads of state visits, and there's just this feeling of you can do anything, and there's so much achievement going on. And I think then coming back to Australia, I really wanted to bring into the Imagex Institute, really wanted to bring that, I guess, entrepreneurial, can do anything attitude that just sort of seems to be common at Stanford, and to almost, challenge myself to be able to do this in an environment that's not Stanford. And, Sydney University is fantastic, and it's one of the top universities in the world. They've been very supportive to allow us to build the program that we have today. And Richmond was the first taste of living in America and part of the Old South, the capital of the South during the Civil War. And interestingly, that there is a racial, that there's no laws about segregation, but in general, the African Americans and white lives in different areas. At the hospital, predominantly those who needed who had education were white, and those who didn't need education, administrative assistants and janitors, were African American. But there was just this real sense, sort of that the South, of the time that people have for each other, and the neighborliness is something that really got in Virginia. And then moving to California, which is very different as far as sort of the time people have, because particularly in the Bay Area and Silicon Valley, there's just, overachievers. When we were living in Stanford, all of our neighbors were Stanford professors. So there's just, overachievers. And it's not really a slice of reality where we were living in the Bay Area. The breakthrough that we had at Stanford University was working with the team at radiology. They were very strong at MRI imaging, which is, again, something that physicists have developed, which is now common around the world, and radiation therapy. And so with that, from those discussions, we decided, why don't we integrate MRI with the cancer radiotherapy system and build an MRI LINAC. And so we started the designs of the system while I was at Stanford. Unfortunately, when I was coming back to Australia, we were successful in receiving funding, and were able to build a world unique system that could use MRI to image the cancer and a radiation beam to target the cancer. And that was one of the projects that was funded by the ACRF in our 2017 grant, and has been a very successful program for a very successful scientific and training program. So MRI stands for magnetic resonance imaging, and I think, to me, it's the most complex of the medical devices, and amazing when we look back at the innovation needed to be able to combine the use of magnetic fields and radio frequency to tell us about the different tissue properties anywhere within the human body. So with magnetic resonance imaging, we are using magnets and combining that with radio frequency imaging of the patient to tell us about the nature of the tissue within the human body. And we can tell whether that the tissue is cancerous or not, because of the difference of the signal that we're getting from the patients. And it's also incredibly flexible, and we can image the body in so many different ways with MRI. So it's much more flexible, for example, than X-ray imaging. I've been practicing medicine for thousands of years, and in the absence of X-rays, then of course we would use our eyes and our touch, and that's still very much a core part of medicine. And even cancer cancer diagnosis. Just yesterday, a dentist was looking in my mouth and checking for head and neck cancer. Obviously, for prostate cancer, there's still that feel, and you go to the dermatologist, and they will look for skin cancers. So human observation is very much a core part of medicine, and then that is augmented by some of the diagnostic tools we have, from X-rays from 1895, and then X-rays morphed into computed tomography or CT imaging in the 1970s to be able to get full three-dimensional pictures of the human body. We also have magnetic resonance imaging, the combination of magnets and radio frequency to image the human body. And there's also nuclear medicine as well. And with this, we ingest radioactive particles, and detectors outside the body can image where these particles have traveled to, and again help us diagnose where in the body the cancer is.
That's right.
So one thing about cancer is that it's very personal, and so one thing we need to do is understand just what specific types of cancer cells are. So once we use imaging to detect where the cancer is in the body, often they'll take a biopsy, putting a needle inside the tumor, often using imaging to guide where that needle is going, to take a sample of the tissue and then analyze that and understand what are the types of cells, and what is the type of cancer cell, and even within those cells, what are the characteristics of those cells? Are they more likely to replicate quickly? Are they more likely to respond to different types of treatment? And so we take all of this information of the physical exam, the patient's history, any other problems the patients may have that may impact the treatment, the biopsy, and the imaging exams, all of this big information, and then to try and make the decision on how best to treat the individual patient to achieve the best outcomes. Often that's done through a multidisciplinary tumour board. We do have experts from medical oncology, from pathology, from radiology, radiation oncology, surgery, coming together and really debating based on the evidence, what the best treatment is for each individual patient. And I think being part of those multidisciplinary tumour boards gives you a really good feeling about healthcare and how much care doctors have for patients. The work we're doing today is we're looking at probing how we can image patients in real time. So really at a sub-second level, and we're taking images from kilovoltage X-rays and megavoltage X-rays, combining that with surface imaging of this patient, bringing all of that information plus prior information and images of the patient, bringing artificial intelligence in to assist us to make solutions fast, where we can get a full picture of the dynamic human body. And on that picture of the dynamic human body, we're seeing where the radiation is going. And we've also got a closed loop feedback saying what is the optimal way that we should be delivering the radiation. So we're controlling this 3-ton device in real time to maximize the therapeutic ratio for each and every patient at all times during treatment. Cancer patients are treated with linear accelerators, and these are 3-ton devices. They're called linear accelerators because they accelerate electrons from nothing to the speed of light, and then create X-rays to treat patients. We need to focus and shape the radiation beam so that we are just targeting the cancer. In addition to this therapeutic beam, they've also got imaging systems on board so we can image the patient before and during treatment. And so taking one of the challenges is making these cancer radiotherapy systems 3-ton systems just a lot smarter than they are, and utilizing the technology in a much better way, leveraging the digital revolution, leveraging faster computers, leveraging artificial intelligence, and bringing all of that together to improve how we can treat patients. When we're imaging and treating patients, we're using low energy X-rays to image the patient and image the cancer, and high energy X-rays to treat the cancer simultaneously. So it's quite a complex operation. And what we're wanting to do is modulate the high energy X-rays so we can shape that just to the target, to the cancer target in real time, and to use all of the information that we have to make the optimal decision for that patient to maximize the therapeutic ratio. So the cancer radiotherapy systems have got low energy X-rays to image the cancers and high energy X-rays which we use to target and kill the cancer. Yeah, so cancer radiotherapy systems are amazing. They've got low energy X-rays with which we can image the cancer in real time, and high energy X-rays with which we can treat and kill the cancer. So what we're doing is taking the information of the low energy X-rays and all of the information that we have about the patients using artificial intelligence, and then making decisions on how best to shape the treatment beam to maximize the therapeutic ratio and make sure the radiation beam is focused on the cancer where it's killing the cancer and not damaging healthy tissues. Cancer radiotherapy systems are amazing. We use low energy systems to pinpoint exactly in the patient where the cancer is, and we use these high energy X-rays to target and kill the cancer. So we take the information from the low energy and we use prior information about the patient. We use artificial intelligence to make fast decisions, and that tells us where to shape the treatment beam, the heavy beam, to ensure that we're maximizing where it's going, hitting the target, sparing normal tissue, and improving that therapeutic ratio of cure with fewer toxicities.